I'm Roger Cordery. I'm a cardiac anaesthetist and consultant in critical care. I'm actually at Bart's Heart Centre now. I'm going to go through that just briefly. Oscar Wilde very famously said when he was arriving at US Customs that he had nothing to declare except his genius. I'm by no means a genius, but it's just to say that I've got no declarations. Actually, I did start at UCH and at the Middlesex Hospital. This is now a rather fancy sort of complex of modern offices and residential things called NoHo, just north of Oxford Circus, if anyone's interested. We then moved to UCH, the big shiny new green elephant, and part of the reason why I've got an interest in this is that whilst I was here for about 10 years, I did do an orthopaedic list where I actually came across an awful lot of people who had varying forms of hypermobility. Not exclusively, it was primarily a list of patients with dysplastic hip problems, but obviously a number of those had issues with hypermobility. But my main training was actually in cardiac, and I am a cardiac anaesthetist still. I worked here for a long time in the Heart Hospital. It's now a centre for urology, so it's known as the Bladder amongst those who know it. And then we merged and moved to the Heart Hospital, from the Heart Hospital to St Bart's, where we now have one of the biggest cardiac centres in the UK, if not in Europe. My other interest is that I'm an examiner for the College of Anaesthetists for the primary exam, and I sit on the physiology subgroup. And one of the things that we do as anaesthetists, and we hope we understand, or at least some way, is physiology. And that chamber on the top is our Jedi chamber, where the council sit. The other reason I'm here is that this joker on the right there is my brother-in-law, and that's my godson on the left. So there's something about keeping it in the family here. So POTS and anaesthesia. I had heard of POTS. I've seen at least 2 patients that I'm aware of when I was doing my list at UCH who had a sort of diagnosis of POTS. 0.2% of the population is the sort of figure that's bandied around. There are something like 3.5 million anaesthetics given a year in the UK. So that's, 7,000 or so patients who are likely to have POTS. By the time you start splitting that up into individual trusts, or at least individual trusts rather than individual hospitals, you can see that you're probably going to have sort of 20 patients a year, perhaps, who might need some sort of intervention with POTS. So actually, from our perspective, that's a small number when you consider that most places will be giving somewhere in the region of 15,000 anaesthetics a year. Certainly from an anaesthetic point of view, I think it's probably unrecognised as an issue. And when you include, are there any surgeons in the audience? I doubt it. When you start including surgeons, they won't have a clue what this is. And just interesting looking at this notice here, I think these are the 2 things that, from our perspective, is probably the most important thing. It's about flagging this up and trying to learn and understand what the syndrome is rather than what we can do about it. We've mentioned, obviously, a number of the associated conditions over the course of the morning. Chronic fatigue, that has implications for pain management, acute pain management postoperatively. We've mentioned hypermobility. And there seems to be some sort of specific things that may be the primary reason why they present. So my line of work, mitral valve prolapse, or people needing inflammatory bowel disease or whatever. So it's sort of out there and probably ought to have a bit more of a red flag from our point of view. Again, we've mentioned a lot about the pathophysiology or suggested pathophysiology that's associated with POTS. Autonomic dysfunction of some sort or other seems to be a big problem. Hypovolemia is an issue. We've mentioned about deconditioning, and Dr. Simmons' talk actually probably is more important from my perspective about prehabilitation, trying to get patients fit for anaesthesia, or more accurately fit for surgery, is probably very, very important in the general public, let alone in patients with a specific disease. And again, the anxiety, hypervigilance side of things, more relevant for the pain management and expectations post-operatively. I sort of put hyperallergenic POTS there as a separate thing, just because that seems to have the opposite effect in my line. Patients don't normally get hypertensive when I put them to sleep or lie them down, whereas this lot can. So what is anaesthesia? I mean, the biggest problem we have with anaesthesia that's relevant to this is the autonomic changes. essentially everything that we do will aggravate all the signs and symptoms of POTS. Yes, our patients are lying down most of the time, but as soon as we put these patients to sleep, they get profound vasodilation. Something like 2/3 of your blood volume sits in your venous system. It's almost all venodilation. We get myocardial depression from a lot of our drugs, and that's, although a smaller proportion of anaesthetic interventions in the UK anyway, with regional anaesthesia, so epidural, spinal anaesthesia, that vasoplegia is profound. In the continent, they use a lot more regional anaesthesia. The UK's got a very sort of strange, oh, you're not sticking a needle in my back sort of thing, except in obstetrics. And the analogy that's always sort of given is of a balloon. You know, you fill a balloon up with water, and all it will do is keep expanding because there's no tone. The tone isn't strong enough. And that's what we sort of end up doing, is we end up trying to give drugs to squeeze everything. There are other things that we do. Positive pressure ventilation. We heard somebody sort of mentioning about Valsalva manoeuvres. Especially in patients who are hypovolemic, positive pressure ventilation can cause further aggravation of hypotension and reflex tachycardias and things. Probably the main issue actually is not so much anaesthesia, it's what the surgeons do. They stick knives in people and cause bleeding. Sometimes they're quite good at controlling it, other times they're not so good at controlling it. And if you're already starting off on the back foot because you're already got relative hypovolemia, we're playing catch up from the start. Pneumoperitoneum. So if you consider that a lot of the population with POTS are young females, thankfully a lot of them don't need to come for surgery, but a lot of them do come for gynecological procedures. And these days we're all doing it laparoscopically. We're all doing it via telescopes. And actually, although laparoscopic surgery in the longer term is probably better for outcomes, a pneumoperitoneum is actually a really, really difficult physiological insult. More so a problem with people with things like ischemic heart disease, but in the POTS population it would probably be a big problem. And the surgeons seem to like putting patients head up, head down, left-sided up, left-sided down, all sorts of positions, which if you've got a problem with positioning, we're going to run into trouble. Okay, so what's the evidence base? This is what I thought would be easy. Look up the evidence base, crack on. Right, there are 4 papers. The biggest study is the one on the bottom left there, where somebody from the Mayo Clinic I can't see the date, I think it was 2010, did a study of 13 patients who had a diagnosis of POTS undergoing anaesthesia for some reason or another. That's it. That's the evidence base. They sort of said, well, 3 of those 13 patients had a bit of hypotension, more so than you'd expect from a normal anaesthetic. And it went away afterwards. Okay, thanks very much. The other ones, as you can see, there's 2 or 3 papers on issues relating to pregnancy and to anaesthesia in pregnancy. I'm going to talk about that a little bit, although we're going to have another talk later on about pregnancy specifically. So what can we do? The key thing, I think, has got to be, identifying the patients, and we've had talks about how we diagnose this, etc., but more about how the hell we make us aware of it. Now, that's an impossible thing. There's 8,500 anaesthetists in the UK, most of whom may see 1 or 2 of these in their career. You cannot sort of put this right up the agenda. But I think in certain risk groups, in certainly the associations with hypermobility syndromes, I think we can sort of flag it up as a potential issue. When we see them, I think if we've got them, we need to see if they have any specific trigger factors other than positioning. Associated syndromes we mentioned. And it's worth just talking about the treatments a little bit. Midodrine was a drug I'd never heard of. Put it up there, the structure of it up there next to noradrenaline, which is below. And although it's a pro-drug, you can see that it's almost identical to, or very similar in structure to noradrenaline. If you're on an alpha agonist and you lie someone down, chances are you're actually going to get quite hypertensive. So again, it sort of kind of goes away from what we would normally expect. Things like fludrocortisone, propranolol are no big deal. We see those in patients all the time. Pyridostigmine is a very rare drug for us to see other than in patients with myasthenia gravis. And what, in fact, pyridostigmine does from our perspective, it makes it hard for our neuromuscular blocking agents to work. So our paralysing agents don't work so well. Clonidine and methyl-dopa and things we've heard mentioned as well. Again, that uncommon drugs to see people on at all, but it tends to mean that they tend to go a little bit more hypertensive. I mentioned this earlier. The evidence base of 13 patients, 3 had prolonged hypotension post-induction of anesthesia. Nobody's quite sure the significance of it. If you're hypotensive and supine, actually your flow to your vital organs doesn't actually change that much, especially if you're young and otherwise fit. So quite often we sit there with a pressure of 70 systolic going, she's 25, it doesn't matter. So, again, a part of it is, well, when do you intervene? Should we intervene? It's a difficult one. One thing that came out of some of the, I think it was the consensus thing was, should you consider invasive monitoring, so putting arterial lines in these people? Well, you just need to see one black hand because you've put an art line in someone, and you get very wary about doing that unnecessarily. Nick mentioned the Finapres earlier. They're not reliable in intraoperative conditions when often the arms are down and out of the way, so it's not a clear one. Invasive monitoring might help. These are the sort of traces that we see in somebody who's hypovolemic. This is off the internet, but it's got this sort of classic swing, and that will be with positive pressure ventilation. It gives us an idea about fluid management, how should we give some vasopressors or something. So it can be useful. As I say, it's primarily dictated by the type of surgery and the changes that are going to occur because of that, rather than because of something else intrinsic with the patient. Hyperhidrotic POTS, we mentioned the hypertensive response. There are some drugs that can trigger a bit of a hypertensive response that are increasingly used in anesthesia. Ketamine comes and goes. It seems to be having a resurgence at the moment. It tends to cause a bit of an increase in blood pressure. And some of our vapors do. Desflurane's a relatively modern drug which can just raise your catecholamine levels a bit. Pregnancy. Without going into detail, regional anesthesia is by far and away the most sort of the preferred technique for cesarean sections, for analgesia, etc., in sort of late parturients, past the second trimester, third trimester. If you put a spinal in these people and they've already got some sort of autonomic problem, then their blood pressure will go down. The thing, I don't do obstetrics, thank God, anymore, but the trend over the last sort of 10, 15 years has actually been to run them on low-dose phenylephrine infusions. Phenylephrine is an alpha agonist as well. And so we're already sort of doing what we would do anyway for POTS patients. We were already doing that. So I'm not too sure whether or not it's significant. There's possibly some evidence that rather than putting a patient through labour who's got a hyperadrenergic type syndrome is probably beneficial. And that's, again, sort of the opposite. You've got somebody who's got a sort of exaggerated adrenergic response to pain or whatever it is, put in an epidural, bit of vasodilation, lose the pain relief. You're going to hopefully have done that response. Postoperative care. We always say this in anaesthetics. Ideally, it should be done in conjunction with the specialist. I think we've realised that person, one person doesn't really exist. Okay, great. If you happen to be in a centre where you've got somebody locally who can advise, fantastic. But I suspect that's not always the case. I phone Nick, it's easy. We've mentioned sort of mobilisation just in general. A lot of the drive in anaesthesia and surgery these days is to get patients out of bed, get them out on the day, hip replacements, get them up on the day, we'll move. That broadly is a beneficial thing. Clearly, that's not really going to be an easily achievable goal in some of these patients. There is, therefore, some sort of theoretical risk of increased deep venous thrombosis just because they don't move so much. Again, theoretically, respiratory compromise, if you're stuck in bed, it's slouched or whatever it is, you're going to potentially run into trouble. Maintenance of any specific treatments they've been on for their POTS is probably beneficial. It does depend a little bit what they're on, but ideally that would be there. Interestingly, somebody else mentioned cyclazine as a positive thing. In hospitals, we tend not to give cyclazine orally, or at least not perioperatively. And that's mainly because if you're feeling sick, you're not going to be wanting to take a tablet. So we tend to give it either intramuscularly or intravenously. Cyclazine is actually a really dirty drug. Yes, it's an antihistamine, but it's also an anticholinergic drug and tends to cause quite a lot of pain and tachycardia. So if you're trying to avoid tachycardia, don't give a drug that's going to cause tachycardia. Pain, we've mentioned some of these things. I'm by no means a pain specialist. Chronic pain, in fact, it would be interesting to get a sort of chronic pain specialist to come and maybe to the next one of these. Some of the sort of hypervigilance, the anxiety, the chronic fatigue type things all have an impact on acute pain management, as well as any other chronic pain issues that they may already have. Clearly, multimodal, multidisciplinary approaches, physio, sort of managing expectations, all that sort of thing is very important and needs to be sort of in many ways addressed pre-operatively. Regional neuraxial techniques, despite the caveats with regional techniques, if we can put an epidural in or put a nerve block in, then they often have no pain. Fantastic. The slight issue with that is that many patients certainly with some of the Ehlers-Danlos type syndromes, genuinely have a resistance to local anaesthetics. Why that is, nobody really understands. It doesn't make any sense. It's a drug that acts on a receptor, on an open sodium channel, and why that shouldn't work in a particular subgroup of patients doesn't make any sense. But it's true. They don't respond to it. And I always tell my trainees that if they say they don't work, they don't work. Don't just go, yeah. And that's kind of it, really. That's as far as I can get. I think they're a potentially difficult group. I think the biggest problem is that they're a very heterogeneous group, and we don't really, we can't sort of have a centre for POTS in the UK where all these patients are anaesthetised. I think that would be way too complex. It's certainly not on the radar of most surgeons or anaesthetists, and I think that's probably the most important thing that meetings like this can do. Try and increase the awareness, or at least sort of increase some of the understanding of what this syndrome is and how it might be relevant to us. Multidisciplinary care, we love it. It's the bedrock of almost everything now. I don't think there's many cases of anything where you'll go through an anaesthetic not having been part of some sort of MDT type approach. Mentioned about the maintenance of pre-op maintenance of treatment, and just that pain management could be complicated afterwards. And that's it.